So thank you for the wonderful introduction. I'm very moved. So I was assigned this topic, and so I will try to give some practical indication more than hard science. Here are my disclosures. That's the reason why EMA never calls me as a consultant. And so I thought that in managing a patient with an optic neuropathy, first of all, you have to reach the diagnosis. And nowadays, we have excellent tools to reach the molecular diagnosis quite fast. Then you have to follow the patients, and so the clinical management is important. And lucky enough, optic neuropathies is one of those parts of mitochondrial medicine where you start having some tools to cure the patients, so therapeutic options. And I'll try to give you a couple of slides for the future. Let's start with the molecular diagnosis. I think you all know that Leber's was the paradigm in 1988 for a maternally inherited disorder, finding the first missense point mutation in ND4. And this was done by Doug Wallace, who, by the way, was the one showing that in humans, mtDNA is maternally inherited, as you heard by Niels, I guess, and also others. And nowadays, we know that 90% of patients are easy to recognize as carrying one of the 3 point mutations, the common point mutations in ND4, ND1, and ND6. So they all affect subunits of complex 1. This is a remarkable thing. But you have a large number of other very rare mutations. So that means that you need, if you don't find the first 3, to sequence mitochondrial DNA entirely. But as always in science, for 20 years we considered Leber's the paradigm of mitochondrial maternally inherited disease, until we discovered that you have also a recessive version of this disease. And this was the seminal paper led by Holger and Thomas. We were collaborating with that because we almost at the same time found these cases, but they were smarter than us, and we discarded initially the variant as non-pathogenic, and then we understood that it was very frequent because there is a founder effect in Eastern Europe countries. And clinically speaking, the remarkable thing, and this is a point that Piero Barboni was always underlying with the first patient that we saw, is absolutely undistinguishable from Leber's. So swelling of the fibers, microangiopathy, and all the other classical hallmarks of Leber's are there. And the fact that it might exist a recessive form of Leber's was not actually discovered by that paper. In 2017, Jean-Michel Rosa actually described one single family with a recessive Leber's like optic neuropathy and homozygous compound heterozygous mutations in DUFES2, which is a nuclear encoded subunit of complex 1. And over the time, other subunits has been found to carry these recessive mutations associated with just optic atrophy. And besides complex 1, the new pathway which got involved in Leber's is also the fatty acid biogenesis with MECR and MCAT, two genes in this pathway at the beginning, at the end of the pathway. This was nicely shown by Claudio the other day at the mini symposium. So we have another possible pathogenic mechanism leading to a subacute loss of vision. And this is just, these days, is still published online and needs to be, we don't have the proof yet, but we collected with a large consortium of people, many families, and we have, I guess, 10 different genes or something like that. All of them are subunit, nuclear encoded subunits of complex 1. All of them are actually related to optic atrophy, isolated or with some milder neurological impairment. And I remind you that these are the same genes where we used to have only mutations associated with Lee syndrome. So the paradigm is still there. A complex 1 dysfunction may have a spectrum of clinical expression from isolated optic atrophy to devastating disease like Lee syndrome. So let's switch to dominant optic atrophy. This is the sister disease of Leber's. In 2000 was discovered to be associated with OPA1 mutations, and I guess 60–70% of patients are still nowadays being diagnosed with OPA1 mutations, dominant OPA1 mutations. OPA1 is a key gene in the machinery for fission and fusion for mitochondrial dynamics, and it does a lot of other things. And so besides complex 1, dynamics of mitochondria seems to be a key point for maintaining healthy retinal ganglion cells and the optic nerve. Over the time, literally each single gene involved in mitochondrial dynamics has been associated with mutations leading to optic atrophy, which most frequently is non-syndromic, but it might also be associated with a larger syndromic widespread clinical expression. Then it came, maybe not surprisingly, but maybe also surprisingly, this other couple of genes, they're both AAA proteases, and these are well known to neurologists because AFG3L2 is also known as spinocerebellar ataxia 28, and SPG7 is also known as paraplegia, because they are associated with spinocerebellar ataxia and spastic paraparesis. But we already knew that some of these patients, they might have also optic atrophy. And it's a matter of fact that you have an entire collection of mutations, of variants, which are associated with pure non-syndromic optic atrophy again. And here the paradigm is that these two proteases process OPA1, and because of the mutations, the OPA1 processing is wrong, and so possibly the pathogenesis is still within the frame of a fission-fusion disorder. Then this was another surprise that complicates further the scenario of inherited optic neuropathies. SSBP1 is an important factor of the replisome, so this is one of the key proteins needed to replicate mitochondrial DNA and leads to mitochondrial DNA depletion. But anybody in this room knows that mtDNA depletion is usually associated with a very dramatic clinical expression in infantile cases, frequently leading to death in a few months. Well, these are well-grown people, adults, and they have a retinopathy, very peculiar optic atrophy associated with the foveopathy. They have a little hole under the fovea, which is a hallmark for this kind of optic atrophy. And frequently, this clinical feature is associated with renal failure, which leads the patients to kidney transplant. And the key point here is that this disease is associated with a relatively profound reduction in the copy number of mitochondrial DNA, which is also the feature of ACO2 mutations. So a new paradigm for dysfunction of the optic nerve is a reduction of mtDNA copy number. And so for those of you which are interested in diagnostics of optic neuropathies, there are these 3 papers which collect very large cohorts and give you kind of a hierarchy of which gene is more frequent and which one is rarer. So we have a very large landscape from the diagnostic point of view nowadays. So what we do in practical terms in our center, if it's an optic atrophy, which is not with the hallmark of Leber's, we just do the exome sequencing. And we eventually filter all the known genes out of the exome sequencing data. And if nothing is there, we can look at more carefully, looking at the entire exome. But if it's a subacute loss of vision, maternally inherited or recessive, then you have to screen first for the 3 common mutation, and then you do the exome sequencing. In our lab, we do exome sequencing, including mitochondrial DNA. So we sequence everything at once, and then we filter for variants. The large majority of these genes are primarily involved in mitochondrial biology. We're now starting seeing something which involves mitochondria as a secondary hit, but the large majority, these are proteins which live into the mitochondria and provide some key function. And as I already said, complex 1 is one of the key pathways. mtDNA maintenance is another one. The interaction between mitochondria and endoplasmic reticulum seems to be another key point. Wolfram syndrome is a case of a protein which is technically is not a mitochondrial protein, but you might have secondarily some involvement of mitochondrial biology. And now we have the fatty acid biosynthesis and many other pathways. Let me just give you a final highlight on the newest genes, which again break some of the paradigms. CRIAB, for example, is very interesting because it's associated with a dominant optic atrophy, but clinically speaking, these patients have a subacute evolution of the visual loss. So they look more like Leber's than dominant optic atrophy. So if you have a Leber's with dominant transmission, you have to look for the CRIAB mutations. And this is a partially mitochondrial protein. It's not really very clear what it does, but it seems to be involved as a chaperone. It seems to be involved in controlling the predisposition to apoptosis. And the other gene, which is also very peculiar, is PPIB. So the first paper, and the only paper now published, this one here, reports many families from Austria. All of them have one single mutation, but there is no founder effect. So it looks like a recurrent dominant mutation in the same position. And we immediately looked in our cohorts and we found about other 50 cases, always did the same mutation. So this is something that is really a peculiar situation that we are now trying to understand better. And this is again dominant optic atrophy. And again, there is a peculiar clinical feature, which is late onset. So dominant optic atrophy is remarkable for being a childhood disease. The onset is usually before 10 years of age. And these patients actually have a slow deterioration after 30 years of age. So, clinical management. The natural history of Leber's is now pretty well understood. There are stages. Everything happens within the first year after the onset, and you go through a phase where you have visual loss deteriorating very fast in about 3-4 months. Within 6 months, you are at the nadir of the visual loss, but structure analysis by OCT, they still show a dynamic situation. So from 6 to 12 months, we call this phase as a dynamic because visual loss is already happened, but fibers are still swollen, then progressively they're lost, and the initial temporal pallor enlarges until it invades the entire optic disc. And at the end, you enter the chronic phase after 12 months. And optical coherence tomography, as Piero Barboni has described in the mini symposium yesterday, is an extremely interesting tool to follow these patients, looking at the retinal ganglion cells in the early phase and at the retinal nerve fiber layer in the later stages, and gives you an information about how the disease progresses, how fast. And the other thing is that you always have a similar pattern as a stereotypical progression of the disease, which starts from the temporal fibers, the papillomacular fibers, which, as you already heard, are the thinnest, and then the degeneration invades from the temporal side, and the inferior side invades the superior quadrant. And in the most severe cases, as the last one, only a few fibers are left on the nasal side. And so the progression is always following the pattern of the fiber caliber, axonal caliber. Dominant optic atrophy is a slow, relentless, progressive disease. Sometimes it's very stable for years, and then you have a deterioration, but is completely different from Leber's. And usually it starts in childhood age, and frequently is not the kid complaining that it doesn't see well, but the parents are actually recognizing that he's not able to do things properly because he has some visual impairment. So these people is usually adapted to the fact that they are almost born without the full vision, and for the milder cases they can actually reach adult age and you will get the disease diagnosis just because when you try to get your driving license they will recognize that you don't have the full vision. Of course, there are syndromic, more severe multisystemic syndromes associated with OPA1, and this is the so-called plus phenotype. This happens with many of the genes that I described. We have milder version, only optic atrophy, severe version with other multisystemic involvement. So in the last consensus, which is now being revised, we gave some very simple indications on how to follow the patients. Here is particularly applied to Leber's, but I think you can extend the same rules to all the patients. Essentially, you have to use three tools. The most informative are visual fields, visual acuity assessment, and OCT. And I know that neurologists like neurophysiology. It's an ancillary testing, can be helpful, but is not the key assessment that you want to do in these patients. And how frequently? For Leber's, which is a catastrophic, very rapid deterioration, since the onset, we usually follow every 3 months the patients, so during the subacute and dynamic phase within the first year after the onset. And then we follow the patients every 6 years. And once they get into the chronic phase, 1 year is more than enough. Once a year is more than enough. Some very trivial things that you want to check. If you have vitamin B12 and folate deficiencies, this needs to be corrected. You have to suggest patients not smoking and not drinking and having a proper diet rich of antioxidant. There are some drugs that needs to be avoided. We saw before with Julio the interesting example, but that's not the case for Leber's, but some specific antibiotics needs to be avoided, or other toxic exposures. And Leber's, in the scenario of inherited optic neuropathies, is the only case where you have a spontaneous recovery. You don't have it in dominant optic atrophy. This spontaneous recovery is maximized by the therapy that we do, but it might also occur with absolutely no therapy. So let's see the therapy options now. For Leber's, idebenone is approved, EMA-approved therapy. It got recently approved also in UK. I guess it's in the process of being approved in the United States as well. This approval was in 2015, if I'm not wrong, after a convoluted path because it was initially refused based on the data of the clinical trial, double-blind placebo-controlled trial that Thomas was leading, because for the shorter than necessary period of administration of the trial was not able to highlight the therapeutic effect of idebenone, and the primary endpoint was not met. But then with supplementary information over the time, reached the point of being approved by EMA. And nowadays we are facing the second therapeutic option with gene therapy through the allotopic expression of ND4. Essentially, what we do, we recode the ND4 gene with the coding system for being transcribed and translated from the nucleus, and then the gene is engineerized, attaching the mitochondrial targeting sequencing, and by this way is imported into the mitochondria and complements the mutant gene. There have been multiple clinical trials, and to cut the story short, there is a clear evidence of a good outcome as compared with the natural history. But even in this case, the primary endpoint was failed because individual injection in one eye and using the other eyes, sham injected as a control, brought to the bilateral improvement, and this destroyed the significance between the two eyes, and the primary endpoint was not met. That's forced the comparison with an external group of natural history patients. So it's not all that linear. 50% of patients with idebenone treated do not respond, and recently we provided a possible explanation, at least for part of these patients, the non-responders, because idebenone, in order to be in the therapeutic form, is processed by this enzyme NQO1, which is also located in the mitochondria, and NQO1 reduces idebenone, and the reduced idebenone shuttles the electrons to complex 3. And so this is the therapeutic form. If idebenone remains oxidized, it's actually associated at the coenzyme binding site at complex 1 and inhibits complex 1, possibly giving a negative effect. So nowadays the new consensus is discussing the issue of if we need to consider the genotyping of NQO1 for all the patients before we undertake the therapy. And this is particularly true for the 3460 mutation, which is the only mutation affecting the coenzyme Q binding site. And the other interesting thing, the trials, rescue and reverse trials with gene therapy, you can see here the results. Besides the awkward result of having the bilateral effect with unilateral injection, people treated after 6 months from onset was actually doing better than those treated in the first 6 months. And this is completely counterintuitive. So we wanted to look if this applies also to labors. And so we compared in a large consortium of people, untreated patients, patients treated within the first 6 months and patients treated after 6 months. And surprisingly enough, also with idebenone, the best outcome gets from if you treat them later. And this is open to discussion. It's something that we're thinking a lot about, but it's a matter of fact that either idebenone gene therapy does not really aborts the natural progression of visual loss. It maximizes the recovery after you lose the vision. So we're starting to have this idea that you have a refractory period, or whatever therapy you do is going to be very difficult to stop that process once it is started. Then for dominant optic atrophy, we have occasional reports that idebenone may work also in dominant optic atrophy, and here the recovery of vision is clear-cut related to the administration of the drug, because these people do not recover spontaneously vision. So if they recover some vision, it's because you have been doing idebenone. But we expect that the company would undertake a properly designed study before this could be proposed as a therapy, a stable therapy. And for the gene therapy, gene editing, and these other approaches, there is a lot of work done preclinically, but except for one trial with an ASO, nowadays we don't have anything reaching the step of the clinical trial yet. But as we heard from Bobby this morning, it's a reality, the fact that you can avoid the transmission of the mutation to the progeny, to the kids. And 4 out of 8 cases that underwent mitodonation were actually carrying the 11778 Leber's mutation. So the future. It would be really nice, because there is an incomplete penetrance in both Leber's and dominant optic atrophy, that we may understand exactly what are the prognostic factors that could predict who is undergoing the visual loss at some point in life and who is not. And we have now a pending under review grant application about using artificial intelligence and multimodal assessment of these patients. We hope to get the money, and the ideal situation would be having the carriers screened, the mutation carriers, unaffected mutation carriers screened, and you can actually refine the group of those which are at highest risk, and you might focus on those for an extremely early therapy before the disease starts. That would be in the future. And obviously we have heard about all the gene editing. Carlos gave us a very comprehensive overview. Very recently, a mouse model has been generated in Korea by gene editing and has been corrected by gene editing. And mitochondrial transplantation is the other thing that is very hot at the moment. Even there is a lot of perplexity, and I would be careful to understand exactly how this strategy works. So, at the end, I worked over 30 years literally with everybody in the field. You can recognize many faces here that are actually in the room, like Thomas Holger, Chiara, Claudio, Holger, Thomas. I'm trying to blind you. And last, I would also like to keep alive the memory of Francesco Pallotti. He was a really good friend of mine. And I'm mentioning him here because we both cooperated in the seminal paper where the allotopic expression, which then generated the trials that we're running now, has been done as a proof of principle in the cells that I brought from Italy to New York. And we helped Jonga in recoding with the nuclear code the ND4 gene and testing the allotopic expression strategy. And this is a recent picture of Francesco. We were for the birthday of Billy with LHON. So we need to remember him. Thank you for the attention.